Welcome to PGOG postgraduate class in obstetrics and gynecology, and this class or this series will also be useful for undergraduates, and that is why it is written as class also for undergraduates. Now this is a new series which we are starting, and the name is Must Know Obstetrics, and the first topic is maternal pelvis. There are four bones, four joints, and four planes in pelvis. You remember, it's easier to remember that way. Sacrum, coccyx, and two hip bones are there. Hip bone has ilium, ischium, and pubic bones. Pubic symphysis, sacrococcygeal joint, and two sacroiliac joints make the four joints. Whereas we have four planes: plane of inlet, plane of pelvic outlet, plane of mid pelvis, which is also called as plane of least pelvic dimensions, and plane of greatest pelvic dimensions is of no obstetric significance, and that is the reason why the newer editions of the textbooks have stopped describing this plane. So though there are four planes, whenever we study the pelvis now in modern obstetrics, we focus only on these three main planes. Now, how do you hold pelvis? Because it is the most commonly asked questions related to pelvis are most commonly asked in your table viva, whether you are appearing as a undergraduate student or postgraduate students of the obstetrics and gynecology. And the first thing is the examiner is observing how do you hold the pelvis. So what is the correct technique is there is a marked forward inclination. Remember that pelvis has got a marked forward inclination. Keep sacrum towards near you, or the sacrum should be at the back and pubic symphysis is at front when you are holding the pelvis. I hope that you all have pelvis in your museums and in your instruments trolleys, and you can practice the way I am telling you. Just go and practice in the same manner as I am describing here. Remember that superior border of pubic symphysis is at a quite lower level as compared to the superior border of the sacral promontory. When a woman is in a standing position, there is a difference of 4 centimeters. That means sacral promontory is higher than pubic symphysis by 4 centimeters. Now the correct position will be when the anterior superior iliac spines and anterior surface of the pubic symphysis are in the same vertical plane. So keep it in that way so that you will realize that there is a so much of forward inclination. When we do this, that we keep the anterior superior iliac spines and the pubic symphysis in the same vertical plane, we realize that there is a marked forward inclination to the pelvis. Plane of the inlet makes an angle of 60 degrees with the horizontal. That much of a forward inclination is present in a normal pelvis. Now, one tip is never keep pubic symphysis and sacral promontory at the same level, as it is a commonly committed mistakes by students so many times. They know everything else about the pelvis, but they fumble here when they try to demonstrate and when they are holding the pelvis, and that is why what you remember is sacral promontory is at a higher level, pubic symphysis is at a lower level. Now, as we have seen, there are pelvic planes are there, and these planes help us to divide the pelvis into inlet, cavity, and outlet. Inlet is the plane of the inlet. That is also the inlet of the pelvis. Cavity is the space which is bounded superiorly by plane of inlet and which is bounded inferiorly by the plane of least pelvic dimensions, or it is also called as plane of mid pelvis. So in between these two planes, whatever is the space is present in the pelvis, that is called as cavity of the pelvis. So many times we hear the description that head has entered into the pelvic cavity. So what do you mean by that is head has gone below the level of plane of inlet, but it is still above the level of plane of least pelvic dimensions or plane of mid pelvis. The space between this plane of least pelvic dimensions and plane of anatomical outlet is called as obstetric outlet. That is another terminology which is very important to understand, that what is obstetrical outlet or what is obstetric outlet. It is nothing but the space which is present in between the plane of least pelvic dimensions and plane of anatomical outlet. Now, plane of inlet, if you extend it further down, it makes an angle of 60 degrees with the horizontal. This is called as angle of inclination. If you are asked what is the angle of inclination, angle of inclination is the plane of inlet. If extended further down, the angle which is made by this plane of inlet with the horizontal is angle of inclination, and normally it is 60 degrees. Now, if there are, on the basis of this angle of inclination, normal is 60 degrees, but there are two other variants in the pelvis which are called as high inclination pelvis and low inclination pelvis. High inclination pelvis, as the name suggests, the angle, this line goes higher up, so that the last lumbar vertebra, if it is getting incorporated into the sacrum, then we say that there is a sacralization of last lumbar vertebra. In that case, it leads to a high inclination pelvis, which is associated with delayed engagement, prolonged labor, and difficult labor. Opposite will be if there is a lumbarization of first sacral vertebra, then this plane of inlet, this will be at a lower level, so it is called as low inclination pelvis. Angle of inclination will be lower, and this low inclination pelvis is associated with easy delivery. What is axis? Now, for each plane of the pelvis, if a mid-perpendicular line is drawn through that plane of that various planes in the pelvis, we join all the lines with each other, then we get a line which has got a smooth curvature facing anteriorly. This is called as anatomical axis of the pelvis. If you join the axis of the inlet, axis of the mid pelvis, axis of the outlet with each other, you get this curved, smooth curved line, that is anatomical axis. But the fetal head is not passing in this curved manner while its passage through the maternal pelvis. How it passes is, first fetal head is directed in a straight line in a downward and backward direction, and after below the level of these ischial spines, the direction changes to downward and forward. This is called as obstetrical axis, because this is the axis through which the fetal head progresses while its descent into the maternal pelvis. Plane of inlet, it divides pelvis into true and false pelvis. False pelvis is the area above this plane of inlet. True pelvis is the area below this plane of inlet. And whenever we say maternal pelvis, we are mainly focusing on true pelvis. Now, the plane of inlet has got some these bony landmarks. The first anterior are the three, that is pubic symphysis, then there is pubic crest, and then there is a pubic tubercle. Laterally, there is a landmark which is called as iliopubic eminence. After pubic tubercle till iliopubic eminence, we have pectineal line, and then we have iliopectineal line from this iliopubic eminence to the ala of the sacrum. Together, this iliopectineal line and this pectineal line, along with the iliopectineal eminence in between, this is called as linea terminalis. Linea terminalis is nothing but this bony landmark which is forming the lateral margin of the inlet of the pelvis. Posteriorly, we have in the center sacral promontory, and on the just lateral to the promontory on both the sides, we have anterior margins of the sacrum, anterior margin of the sacral promontory, anterior margin of the ala of the sacrum. All these bony landmarks together are forming this plane of inlet. In the diameters of the plane of the inlet, we have three diameters: transverse diameter, oblique diameter, and anteroposterior diameter. Anteroposterior diameter is called as conjugate diameter because it is the shortest diameter. True conjugate or anatomical conjugate is the distance between the midpoint over the anterior surface of the sacral promontory to the midpoint over the superior border of pubic symphysis, and it measures 11 centimeters. It is either called as true conjugate or anatomical conjugate. There are two oblique diameters. one starting from the sacroiliac joint to the opposite sided iliopubic eminence, and other is from opposite side. Now right oblique starts from the right sacroiliac joint and left oblique starts from the left sacroiliac joint. So it is important because whenever we describe in mechanism of labor whether the head is engaging in the right oblique or left oblique, that is why we need to know that. And sometimes in examination also you might be asked the question how which one is the right oblique, which one is the left oblique. Remember, the one which starts from right sacroiliac is right oblique. The one which starts from left sacroiliac is left oblique diameter. Transverse diameter is the largest distance between these linea terminalis. So necessarily it is never in the midline. Here you can appreciate that it is nearer the sacral promontory as compared to pubic symphysis. This is sacral promontory and this is pubic symphysis, and this transverse diameter is in closer proximity to the sacral promontory. It is the longest distance between the linea terminalis, which is this point is nearer the posterior half of the plane of the inlet. Transverse diameter is the longest diameter and it is 13 centimeters. But anteroposteriorly, we have already seen two or anatomical conjugate is from the midpoint over the superior margin of pubic symphysis to the midpoint over the anterior margin of the sacral promontory. But this we cannot measure in a patient clinically. Second important anteroposterior diameter is obstetric conjugate or available conjugate. It is the available distance for the fetal head while when it is passing through this inlet of the pelvis. And the reason it is 10 centimeters, 1 centimeter less than anatomical conjugate is there is a bony prominence which is present over the posterior surface of pubic symphysis. If you see a real pelvis, not a model, you will appreciate that there is a small bony prominence over the posterior surface of pubic symphysis, and that is why this available distance is 1 centimeter less than this true conjugate. But with these both anatomical or even with the obstetric conjugate, we cannot measure that clinically in a patient, and that is why third anteroposterior diameter has been introduced to assess the inlet of the pelvis. That is called as diagonal conjugate. Diagonal conjugate is the distance between the midpoint over the lower margin of pubic symphysis to the same point posteriorly, that is at the midpoint over the anterior margin of the sacral promontory. Diagonal conjugate is 12 centimeters. Now, how we measure the diagonal conjugate is a most favorite question asked in your table viva. What is the technique? You examine the patient in dorsal position. We should be taking all the aseptic precautions and bladder should be empty. And then when a hand is introduced, palmar surface of the hand is kept laterally and the tip of the middle finger should be touching the sacral promontory. The point on the same finger, which is touching the lower margin of the pubic symphysis, is marked with a pen, and then the hand is taken out, and then that distance is measured. That is how you measure the diagonal conjugate. Importance of diagonal conjugate, if you are asked what is the importance, it is the only diameter of the inlet which can be measured clinically in a patient. No other diameter we can measure, and this pelvimetry, whatever we do in modern obstetrics is clinical pelvimetry. We are not using either X-ray, ultrasonography, MRI or CT scan to do the pelvimetry because all radiological investigations to assess the capacity of the pelvis or adequacy of the pelvis have very poor diagnostic value, and that is why whenever we do the pelvimetry or whenever we assess the pelvis, we do it clinically. So this diagonal conjugate stands at the top of the all the diameters of the inlet importance wise because it is the only diameter which can be measured clinically. Diagonal conjugate, if you subtract 1.5 to 2 centimeters from diagonal conjugate, then what we get is the obstetric conjugate, or we get the available conjugate. That means how much is the available space anteroposteriorly available for the fetal head to pass through the inlet. Inlet contraction is diagnosed if diagonal conjugate is less than 11.5 centimeters. Now, what is here? How I have prepared this topic is as if you are sitting in front of the examiner, and if you say Diagonal conjugate helps us to diagnose inlet contraction. The next question of the examiner will be what will happen if there is an inlet contraction? What is the significance of diagnosing inlet contraction? So significance is inlet contraction leads to malpositions. It can lead to asyncytism. It can lead to occipito-posterior position, leading to failure to progress in labor. It can lead to delayed engagement, early rupture of membranes, cord prolapse, and malpresentation, such as face and shoulder can also occur. If the head remains high up floating, then it can change to either face, or even presentation can change from cephalic presentation to shoulder presentation. Inlet contraction also rarely it also leads to cephalopelvic disproportion. Now, remember that obstetrics is fluid as a science, and sometimes what I have observed is whenever you are facing a practical examination in obstetrics, students sometimes find it more difficult as compared to gynecology because it is interconnected and the viva can go in any direction, and whatever terminology you utter, examiner can ask you definition of that and questions related to that, and the topic can very well go from one easy topic to one which is very difficult. That way obstetrics is poses a greater challenge for students, is my opinion. So whenever if you say it rarely it can lead to cephalopelvic disproportion, examiner will be asking you what is the definition of, how do you define CPD, and that is why I have included whatever terminologies we are using. I have included these definitions. Cephalopelvic disproportion is obstructed labor because of the disparity in the size of fetal head and maternal pelvis. And CPD is said to be rare. It was seen more commonly in the past because of rickets, but now the absolute discrepancy between the size of fetal head and maternal pelvis is less likely seen, and it has been seen even that even if you do a cesarean section in a priming gravida for a CPD in a patient, sometimes same weight baby she can deliver vaginally in the subsequent pregnancy. So this absolute discrepancy is less likely to be there, and what is more common is, as we have already seen in the last slide, that there can be failure to progress, there can be delayed engagement, and there can be overall problem in the progress of labor. But to call it as cephalopelvic disproportion, this entity is rare as compared to failure to progress. What is obstructed labor is when there is no progress of labor in spite of good uterine contractions. That is the definition of obstructed labor. How do you define failure to progress? Failure to progress is lack of progressive cervical dilatation or halted fetal descent in labor. Engagement is, everybody must be aware what is engagement, but for sake of completion I have included it. It is the largest transverse diameter of the fetal skull, that is biparietal diameter. When it crosses the plane of inlet, then we say that head has engaged. Early rupture of membranes is whenever there is a spontaneous rupture of membranes, back of membrane ruptures spontaneously before full dilatation of cervix. This is another definition which is of importance, and I have used this terminology in the previous slide as asyncletism. So let us see what is this asyncletism. This is a type of engagement. We have two types of engagement of the fetal head. One is syncletism and other is asyncletism. What is syncletism is when head engages as it is passing through the plane of the inlet of the pelvis. The sagittal suture is lying exactly midway between sacral promontory and pubic symphysis. Then it is called as a syncletic type of engagement, which is seen in only 25% of the normal vaginal delivery. Whereas remaining 75%, or what is much more common, is asyncletic type of engagement or asyncletism, where a sagittal suture is deflected off the midline. It can get deflected either to anteriorly nearer the pubic symphysis, in which case posterior parietal bone will be at a lower level or presenting, and then it is called as posterior asyncletism. Or it can be like a sagittal suture can get deflected posteriorly, and in that case anterior parietal bone will be the one which will be seen mainly when we do the pervaginal examination, and then in that case it will be called as an anterior asynclitism. Now, mild to moderate degree of asynclitism is a norm for vaginal delivery. That means the head gets tilted to one side and the sagittal suture is deflected to one side, and one parietal bone descends followed by the other, and with further descent is gets corrected, and the asynclitism always gets corrected with further descent of the fetal head. But if there is a severe degree of asynclitism, it leads to problem in delivery then we diagnose it as a case of cephalopelvic disproportion. Here, as you can see, this is sacral promontory and this is pubic symphysis, and synclitic engagement where sagittal suture is exactly midway between these two. If the sagittal suture is more near the sacral promontory, anterior parietal bone presents, then it is anterior asynclitism. On the other hand, if sagittal suture is nearer the pubic symphysis, posterior parietal bone will be the main which will be palpated on per vaginal examination, and in that case we call it as posterior asynclitism. Now coming to the plane of mid pelvis, that is also called as plane of least pelvic dimensions. It passes through ischial spines laterally. Anteriorly, it is passing through lower margin of pubic symphysis, and posteriorly, it passes through sacrococcygeal joint. Transverse diameter is the distance between the two ischial spines. It is around 10 centimeters. Antero-posterior diameter is 11.5 centimeters. Importance of this plane of least pelvic dimensions is it indicates zero station. You all must be aware that whenever we assess the descent of the fetal head, we say that the head is at +1 station, -1 station, and so on. So ischial spine level or this level of plane of least pelvic dimension indicates zero station. Axis of the pelvis changes here. Initially, it is from inlet till the plane of least pelvic dimensions. The axis of the pelvis is in a straight line downward and backward direction, which changes to downward and forward direction. So there is a change in the axis, or change in obstetric axis, or change in the way the fetal head descends. And practically it is important because if we are applying forceps or vacuum, we appreciate, or we should exert the force in the same direction, downwards and forwards, as the head starts emerging out of the vagina. This plane divides cavity of the pelvis from obstetric outlet, which we have already seen in the previous slide. And obstructed labor can occur at this level, because it is least pelvic dimensions, means capacity of the pelvis is least. You can see that both the diameters together are forming a crowded area here, and sometimes the head passes through the inlet, but it gets stuck here. That is why it is of importance. Now, plane of anatomical outlet, it is less likely to cause obstruction. It is outlet obstruction goes hand in hand with the mid-pelvic obstruction. Rarely it leads to a obstruction as a separate entity. This plane of anatomical outlet can be described with the help of two triangles with a common base formed by the line joining the two ischial tuberosities. Posterior triangle, the apex formed by tip of the coccyx and sacrotuberous ligament are the lateral margins. Anterior triangle is formed by the subpubic angle, which is 90 to 100 degrees, and there is a subpubic arch here. Pubic arch is here. That forms the anterior apex of this anterior triangle, and descending inferior pubic rami are forming the boundaries of this anterior triangle. See, so these two triangles together are forming this plane of anatomical outlet, with the transverse diameter is distance between the two ischial tuberosities, which is 11 centimeters. Antero-posterior is from the lower margin of pubic symphysis to the tip of the coccyx, when the coccyx is pushed posteriorly by the descending head. And then in that case, this AP diameter is 13 centimeters. Now, what is most important to appreciate is, here till this time we were talking about mainly the diameters and the size of the pelvis. But we need to understand that size is not the only component which is of importance. Shape of the pelvis also decides whether a patient will have a vaginal delivery or not. And for that, there's anatomical classification is important, which is called as Caldwell-Mollay anatomical classification of the pelvis. It is based on shape of pelvis. Shape of the inlet differs in the four types which are present as per this classification. Inlet, the shape of the inlet differs. Transverse diameter of the pelvic inlet helps in this classification in the way that posterior segment determines the type of the pelvis, anterior segment determines tendency of pelvis. Because what is seen in the patients is the pelvis is not purely of only one type. Sometimes posterior segment of the pelvis is say gynecoid type and anterior is android type. In that case, what we will describe it as it is a gynecoid type of pelvis with android tendency because anteriorly it is of android type. Diagrammatically, here we can see this Caldwell-Mollay anatomical classification of the pelvis. Most common type of pelvis is gynecoid pelvis. Then we have this android pelvis, anthropoid pelvis, and the least common is platyploid or flat pelvis. As you can see here, the in gynecoid pelvis, this transverse diameter is nearer the sacral promontory, slightly nearer the sacral promontory, but the shape of the inlet is almost circular. On the other hand, anthropoid is where the anterior, what you can appreciate is anterior diameter is much more enlarged as compared to normal. In the android, there is an anterior narrowing of the pelvis, and this transverse diameter is much nearer the sacral promontory as compared to a gynecoid pelvis or a normal pelvis. Whereas platyploid or the flat, as the name suggests, it is stretched transversely, with transverse diameter being much enlarged as compared to the normal pelvis. So to remember the diameters, you can make this chart and keep this chart on the wall in your room so that it has to be at the tip of the tongue. For example, if obstetrics, these are the must know areas and there is these are non-negotiable areas as far as passing the UG or PG exam goes. So, for example, if you fumble in explaining the pathophysiology of PCOS doesn't matter. Examiner might be kind and let it go. But if you fumble in these diameters of the pelvis, it will be almost considered as a non-negotiable area. So it has to be on the tip of the tongue for you. For inlet, 11, 12, 13, 11 anteroposterior, 12 oblique, and 13 is transverse. Whereas again we have 10, 11, 12 here in the anteroposterior only. Shortest is obstetric conjugate 10. Then we have anatomical 11 centimeters and we have diagonal conjugate which is 12 centimeters. Mid pelvis or plane of least pelvic dimensions anteroposterior 11.5 and transverse is 10 centimeters. Outlet, the diameters are exactly opposite of inlet. Here transverse is the largest, whereas at outlet the largest diameter is antero-posterior diameter 13 centimeters and transverse diameter is 11 centimeters. So at a visually also you can appreciate and you can remember that at the outlet the diameters are opposite of inlet. Thank you so much.